Welcome to the Grow RDH podcast. My name is Katie, and I've been a dental hygienist for almost 15 years, and I'm an educator. I've been an educator for a little over 10 years. I started this podcast with a goal to bring dental hygienists together to talk about current events, professional development, and even some personal issues that we all have in our work-life balance. So thanks for joining me, and listen on. Hey everyone, I'm Katie, back with another podcast episode for Grow RDH podcast. Today we're going to be talking about coronal scaling, specifically coronal scaling by a dental assistant, which I think is a really trending topic, and I think it's a topic that a lot of people go into with passion. I think this is something that we talk about, and it can get very heated, and we're going to talk today about a little bit about why it gets heated. But I want to talk about coronal scaling specifically in the context of ethics and why some of the issues do get pretty passionate. There's a lot of ethical dilemmas or ethical conflicts that go into coronal scaling. So I think it's just a really important conversation to have, because I think it explains and it gives context as to why sometimes this topic can become a little bit heated. Coronal scaling by a dental assistant is right now only sort of being implemented in different ways in two states. Right now, Kansas and Illinois are states that are attempting to implement this in different ways. And I know just from having talks in our state that South Dakota is currently discussing how this might look in our state. And I know there's other states that are talking about it too. If you're in one of those states, get in touch with me. Get in touch with other hygienists in your area. Get in touch with your associations to join the conversation if you also feel passionately about it. Basically, what coronal scaling is for an expanded function for a dental assistant that allows them to scale above the gum line or supergingivally. And it is proposed a lot of the times in the context of access to care, because a lot of our rural areas, specifically in South Dakota, or our underserved areas just generally in the nation, there is talks of being a shortage of dental hygienists. And so this always comes up as a solution to that problem. And I think where the ethics come into this is that a lot of the times when we talk about it as a solution to the problem, there are bigger underlying ethical issues here that really make it not a solution. And bringing those ethical issues to the forefront sort of helps us understand why this is maybe not the best solution. And, if there's underlying problems, there's maybe better ways to address this problem of access to care than coronal scaling. And so let's get into it. Let's first talk about how I want to address this, or sort of outline how we're going to talk about. We're going to talk about patient awareness and codes, and I don't want to throw around a whole bunch of legal jargon, but even when we talk about some of the codes that we're using, really being true to the definition of the code and how it's used, making sure that we're completing the procedures that fall under that code. We're going to talk about that first, and then we're going to talk about maybe some options for how it's employed, what the ethical issues are in each way it's employed. So let's first talk about codes. Anytime we talk about a procedure code that a dental hygienist would use, we're talking about cleaning the entire periodontium to completion. So even if you're using an 1110 code, which is for a prophy, or any of our SRP codes, 4341, 4342, our gingivitis code, 4346, when we're talking about using those codes, when we're entering a contract with a patient, when we choose a procedure that we're going to do, the overall landscape of what those procedures do include the entire periodontium. Even for a prophylaxis, we are cleaning the entire periodontium, supra and subgingivally. It's just in a prophy, that periodontium is healthy. But we still clean under the gum. We still assess the procedures that we do to check below the gum line, the probing and scaling below the gum line. I don't have actual statistics to say the percentage of time we spend on that, but I'm just going to throw out the majority of what we do supra and subgingivally at the same time. I would venture to say that 9/10 of what we do is subgingival and or supra and sub at the same time. And maybe 1/10 of that is spent coronal scaling. And again, most of that is done simultaneously as we do supra and subgingival work. And so when we're talking about using those codes, if we're not doing that, if we're just doing supragingival things, supragingival procedures, we are not ethically fulfilling the contract that we've made with the patient when we're charging them for any of the procedures that I just mentioned. So an 1110, a 4341. If we don't go below the gum line, we're breaking a contract with the patient by not completing the procedure as the patient is aware, if that makes sense. So in terms of how this presents ethical conflicts, I think there's 3 ethical conflicts here that we're going to be talking about. With that landscape, or with that pre-existing knowledge of what the codes we use and the procedures that we do them in, I think 3 options here are available, and either all of these options present an ethical conflict. So let's talk about the first option. The first option, and this is something that was brought up by dentists who have proposed this, is that the assistant would do everything supra first, and then it was the dentist that was planning to come in and complete or finish the cleaning. The ethical problem for me here is you would essentially be doing the same procedure twice, meaning this would almost double the chair time for the patient. So if, for example, we have a patient who has healthy periodontium, we're going to do an 1110 prophy, and we first have an assistant come in, do all the supragingival scaling, polishing, and then we have the dentist come in and do the supra and subgingival periodontal assessment, probing, and finish the cleaning. It would double, almost double. And again, I don't know if this is factually accurate in terms of actual time it would take, but it would almost double if they were doing the whole periodontium to completion, because as we know as hygienists, the services that we do it simultaneously. We do the supra and sub work together simultaneously. And if you think about, if you would actually compartmentalize your job and be like, if you had to only scale supra, I mean, we can't even fathom that. That seems so odd. But if we had to only scale supra, it really would, and then we had to go back and do sub, you would be doing those same procedures over again, and it would be double, basically. So that would be one scenario, and that presents an ethical dilemma because it would double the chair time for the patient. So for access to care purposes and for patient satisfaction and patient comfort and just realistically how that would look, it just seems unfeasible. It does not seem like that would be the option or scenario that would actually occur. The second option is that you're planning to do the 1110 prophy in this example, and in that 1110 prophy, the assistants are scaling subgingivally. In order to get the 1110 procedure completed, if the dentist doesn't have time and we don't want to double the chair time, the assistant would scale subgingivally. And I know that we don't want to make accusations that aren't happening, but I have heard that this does happen. And if this is happening, the ethical implications there is that completely violates the Practice Act they would be practicing outside their scope of practice. Not only is this dangerous in terms of patient safety, in terms of doing procedures that you're not trained how to do, and that violation of the Practice Act on a patient safety realm, it also directly undercuts the dental hygienist as an employee. If they're being allowed to illegally be doing a procedure that a hygienist is trained and educated to do, it undercuts our ability to fair pay and access to jobs and hiring, firing, stuff like that. I mean, on the long game of that, I think it's a really slippery slope. And that would be probably the worst option. And again, I don't want to make accusations or say things are happening, but I do know that I have heard of instances that is happening. The third option is that the dentists are not planning to complete the subgingival scaling because they don't have time. I mean, there is also a lack of dentists in certain areas, and they're not planning to complete the subgingival scaling. They plan to supragingival, scale, and polish. Especially, they always use kids as examples in the articles and the press releases that I've read. You know, kids, like they're saying, well, assistants can clean kids' teeth. They don't have disease. They're not as involved. And one, I completely would agree or not agree. I would disagree with that because I've cleaned plenty of kids' teeth that do have buildup, that do have disease. Braces, for example, those, we get out our Cavitrons for those types of cleanings all the time. But either way, let's go back to, maybe that subgingival scaling and assessment really isn't happening to its fullest extent, and they're still planning on start charging out the 1110 code. That is a big ethical dilemma because it is, one, violating a contract. When you enter a contract for a procedure code that is clearly defined by cleaning the whole periodontium, and you're not doing that, you're breaking a contract with your patient. The patient isn't aware that you're not cleaning subgingivally. And by not doing that code, essentially you're setting yourself up for risk of insurance fraud. And it's misleading. It could cause or initiate some lawsuits against whatever practice is doing this. But that said, aside from those issues, I think that overall, there just isn't a good setup. There's no code for supragingival scaling. There's no outlined plan to, okay, supragingival scaling is allowed. So now how are we going to define or tie that into a procedure that we would actually do and charge for? If not, we're completely misleading the patient on what they're paying for and what we're doing. And I think that's a huge issue. That's a big ethical concern that we as providers really need to think about when it comes to what we're educating the patient on, what we're maybe misleading them on about what they're paying for. And that's a pretty big issue. So those are the three really big scenarios, right? Just to review, either the dentist is going to come in and finish the cleaning and double the chair time, or the dentist is going to charge out the 1110 and allow the assistant to scale the whole periodontium under health, or they're not going to complete the subgingival scaling and they're still going to charge out the 1110 code. So those are the three scenarios. I think that bringing that to light, or starting to talk about what are the potential outcomes if those scenarios were to exist. If coronal scaling in your state gets passed, how are we going to address all three of those very specific ethical concerns? And if those aren't addressed and we move forward with a lot of this, those are issues that are going to come to light when we start employing this and when we start enacting this. If you're from Kansas or Illinois and you have insight onto this, or you've seen cases where ethical issues have happened, please reach out to me or your state association or the ADHA, because I think learning more about how these have been handled and learning about what the options are is a great place to start when we're having these conversations. Again, I can just speak in South Dakota. I know that this is a conversation that's going to be had. They're going to bring this forward. We're going to sort of be addressing the issues that it presents with. And we need to work with insurance companies. We need to work with our assistants. We need to work with the certification programs that they're sort of proposing, right? So they're proposing that this is tied to a certification course where the assistants are trained how to use the instruments supergingivally. And so what does that look like? What does that training look like? How long is the training? One of the biggest concerns is here in South Dakota, our dental hygiene school is accredited by CODA. CODA is a arm of the ADA, and they're requiring so many clinic hours for us to be deemed competent to do this service. So it's important for the ADA to mandate those hours and to really ensure that our graduates are competent and providing safe subgingival cleaning. But yet it's a lot of dentists that are also ADA members that are proposing some of these changes and also saying, oh, but when assistants we're going to train these assistants and it's going to be a weekend course, it's going to be this and that, but it's okay because it's supergingival. And I just don't see the connection between how supergingival scaling is going to fix anything. If we're talking about access to care, if we're talking about employment issues, that's a huge issue. If we're talking about the number and amount of hygienists available and hiring issues, to me, because of these three scenarios that I've brought forward, to me, that answer to access to care, coronal scaling does not solve really any of those issues because of the reasons I gave. If a dentist has to come behind the assistant and do everything sub that we would have already done, it doesn't solve a lot of the issues that they're trying to address by promoting coronal scaling. And so I think it's a bigger conversation. I think it's a deeper conversation that requires a lot more thought into the why. But why do you want this? And what problems does it solve? Because really, I don't think it's going to solve as many problems as they think it would. And we want the training to be there. If this were to go forward, we need the training to be there. But what does that training look like? Is that going to be CODA approved or CODA mandated? And if it is, what do the hours look like? Is it evidence-based? What is the safety of this? And I know in our state, our Board of Dentistry has been very vocal about saying they will not consider anything that's not accredited through CODA, which is awesome. Our state has been very supportive of that, and they understand the purpose and the rigorous criteria and requirements that we're put through as hygienists. They understand that. And I think knowing that gives us a little bit of comfort in that, yes, we have been trained in hours and hours and hours of instrumentation. And so I do think that there's hope there, in that I do think most dentists understand how we are trained, and they understand the importance of the training. And I know that in the dental field, they have that issue as well. I mean, look at implants for oral surgeons and placing of the implants and doing oral surgery procedures. the line has been very blurred there. A lot of dentists can go to a weekend course on this, and now they're advertising. That was a really big thing in South Dakota, even just 1 or 2 years ago, advertising as being an implant dentist, right? And so they were blurring the lines there of, do the public understand that a oral surgeon has a specialty in this very unique and important and rigorous field? Or is it just a general dentist that went through a certification course? There was a lot of heated debate in South Dakota about that. And I think that this mirrors that a lot. This conversation that we're having about coronal scaling mirrors that a lot. And there are a lot of dentists that do understand that and are very vocal and in supporting that, yes, this is a really important thing. But I do think it's important to also highlight those three ethical concerns that I brought forward, because to summarize, I do not think that coronal scaling solves those problems. I think it presents more problems than it actually solves. And if you're coming to that conversation about coronal scaling in your state, if you're coming to that conversation, I think it's really important to consider those ethical dilemmas when you're bringing that argument forward, because it helps people understand why this is such a serious thing. Insurance fraud is a serious thing. Breaking contract is a serious thing. That is something a patient can bring legal action against you for. And so being careful about making sure that every procedure that we do is tied to the actual procedures that we do clinically. I think what I'm trying to say, what the codes you're selecting match the procedures that you're doing. And so I just think it's a really important topic that we're all on the same page on, and really verbalizing well the ethical concerns that come when we're talking about coronal scaling. So if you feel passionately about this subject, which, as you can probably see, I do, please join the conversation. Reach out to me if you are in Kansas or in Illinois and you have experience with some of these ethical concerns that have happened. I think bringing those forward and bringing those to light can help. Also, if you want to join the newsletter, again, I will send these new episodes out in a newsletter, and you can join the community that way. If you are interested in joining the community, I think it's just a really great way to connect and get in touch and get some feedback from other dental hygienists that maybe have dealt with this same issue. So thanks for being here today. Thank you.